Hello, I'm Matthew Weinstock, Managing Editor of Modern Healthcare. Thanks for tuning in to the latest edition of The Checkup. The coronavirus pandemic and the economic shutdown have resulted in millions of Americans losing their jobs and access to employer-sponsored insurance. Serving more than 2 million underserved people in Los Angeles County, LA Care Health Plan is certainly familiar with many of the challenges facing this population. I'm joined today by John Baackes. He's CEO of LA Care to talk about the impact COVID-19 is having both on their members and insurers broadly. John, thanks so much for being with us today.
Pleasure to be here.
So let's talk, I guess, first about just overall the impact that COVID has had on your membership, 2 million in that underserved population, swelling ranks of the uninsured and folks probably going on to Medi-Cal. Just what have you seen?
Well, I think the most important thing to remember is that of the 2.2 million people we represent, a large number of our folks are people of color. And just as we've seen across the country that the pandemic seems to have fallen harder on African Americans and particularly Latinos, and we're also seeing that with our Asian members, we've had a higher infection rate and death rate among those members than the general population. So that's of grave concern to us. Of course, we want to make sure that they have the access to care they have. So that's our main issue in terms of the impact of COVID. On the matter of the number of unemployed people that were expected to storm the doors to get Medi-Cal, we have not seen that yet, and neither have many of the other plans similar to ours around the state. We did a little delving into that and found that back in 2018, UCLA did a study of the Medi-Cal population in Los Angeles County and found that 800,000 of the 3.2 million were working full-time, meaning they had 21 hours of employment a week or more, and 300,000 were working part-time, meaning they worked less than 20 hours. So if 1.1 million of our members already had earned income, my supposition is they were the first to go, because these are probably people who work in the service side of things, either as wait staff in restaurants, kitchen staff, housekeepers, nail salon workers, and those people. So they already had Medicaid, and as we call it, Medi-Cal in California. And that then supports another statistic that's happened here, is we've seen a 200% increase in CalFresh applications, which is California's version of food stamps. So that says to me that many of the newly unemployed were among our members because they were in these service sector jobs that were the first to go. And so they had the insurance, but they didn't have income. So they went and applied for food stamps because they need food. So watching the demand and the impact of food insecurity is another big issue. And we have a community link that people can use to access social services that they're entitled to. And we've seen something like a 5-fold increase in the number of inquiries about how do I get food. So I'd say those are the biggest impacts for us so far, that our members are suffering because they are disproportionately hit by the virus because of their economic conditions. And it's also showing up in the demand for food supplements during this crazy time.
And I know you guys have done a lot on social determinants even before, obviously, COVID. So can you talk about how you've had to ramp up even more, especially on food insecurity for your members?
Well, as you know, people who are on Medicaid, there are social determinants, which is a term that it doesn't seem right. I call it barriers to getting the right care in the right place at the right time because of the circumstances of your birth, your educational status, or so forth. So we've always tried to do what I would call a set of experiments where we would pay for certain social safety net services as part of somebody's care plan, and then collect the data so we can build a body of evidence that shows if we invest in the social services, we'll reduce healthcare costs later. So we've taken we have about 10 million a year that we've been able to set aside for community health investment grants over the years. And we've redirected almost all of that for this year to homelessness or to food insecurity. So a number of grants have gone out to organizations to make sure we can house as many people as possible, particularly the most vulnerable who are on the streets, and to support certain safety net programs. One grant we did was to Project Angel Food, which provides home delivered meals to people who are who can't get out. Generally starts with people who are at end of life illnesses. And we have funded paying for 150 of those people on that waiting list of our members to get food for a year. And it's a drop in the bucket, but it's the kind of thing we do. Now, we also study the utilization after they are receiving food in this kind of manner to see if it has, what impact it has on their use of healthcare services. And we're involved in a number of other funded demonstrations like that are attempting to show that investments up front in these social determinants to mitigate them is going to pay off later in less healthcare expense.
And how are you supporting that financially? Because obviously COVID probably having some sort of hit on on you as well.
Right. Well, so for as I mentioned, we have generally set aside $10 million a year out of our retained earnings for these community health investment funds. So that money was already allocated for this year. Now, so far, in terms of financial impact on a plan like ours, the state of California has decided that they will take a 1.5% retroactive rate cut on the premium we've been receiving since July of 2019. We're in an unusual 18-month rate period. We'll go back to 12 months beginning January of 2021. But they went back and said, well, we're in dire straits. So they are clawing back that money beginning in September. So that's the only impact we've had, and our reserves have been able to absorb that. We have not had to go back to any of our providers, doctors, hospitals, skilled nursing facilities, or anyone and claw back any of their payments. So that's why you have reserves for times like this. So that's been the only impact so far. However, the new rates will come out in January, and the state passed a budget for the fiscal year that began July 1st, and they penciled in federal aid that has not even been introduced into legislation yet. So if Congress does not pass a fourth stimulus bill and goes home in August without it, we're going to be right back at the table in Sacramento talking about up to $14 billion in cuts, which will be cuts in benefits and cuts in reimbursement that will necessitate us renegotiating with our providers because of what if they have to do that without this additional federal aid. So we're in a very unusual period in that we know that there's going to be new rates in a little over 5.5 months. We have no idea what they will be yet because it is dependent on federal aid that hasn't even been introduced yet as legislation.
So what kind of uncertainty does that do to your just planning cycle? I mean, it's got to create a whole level of uncertainty.
Well, it is because our fiscal year begins in October. So we've drawn up a budget and we've done a 3-year projection, assuming that there will be cuts of the nature that were discussed during the state's budget run-up. And it's going to be a grim 3 years. We will probably, at least in one of those 3 years, lose money. But again, that's what you have reserves for, to get through a crisis like this. So we're battening down the hatches, if you will. All of our workforce is off site now. They have been since the middle of March, and they're happy to be working from home and feel safe and feel supported. And we've made a decision that we're not going to return to the office until January. That's the earliest we'll do it. And that will be reviewed when we get closer to January because we don't know where the pandemic will be, and it'll be in the middle of flu season. And we're really working on with others on a PR campaign to make sure people this year more than ever get flu shots because you want to reduce the risk and the demand on the system that the flu victims might have if we still have a pandemic that's going at the rate it is right now.
Sure, absolutely. And I think a lot of people are anticipating that sort of collision course of the two things.
We're very concerned about it because flu, as you know, kills a lot of people every year. And the number of people who get flu vaccines is, shockingly low. It's in the 30% somewhere. And so we're very concerned that we have some sort of campaign to alert people and do everything possible to make sure that they can get access to flu vaccines.
John, too, I want to come back a little bit to the reimbursement and provider side of it. I know you guys have been doing some accelerated payments to providers who are, hemorrhaging money because they've had to cancel elective procedures and other revenue generating things. How has that process gone? And do you imagine that that's going to continue through the remainder of the year, or will you dial that back?
Well, first of all of our medical groups that contract with us are under capitation agreements. So all of our primary care physicians have been getting paid based on the number of people in their panel, regardless of whether they've shown up in the office or not. So they're in better shape than providers who depend solely on fee-for-service, which the specialists in some of those groups get paid that way, but we've already paid the groups, so we hope they're balancing that out. Some of our bigger hospitals are also under capitation, so the 4 public hospitals here in Los Angeles are all under capitation payments, so they've been getting, again, the same payment every month based on the number of people impaneled to doctors who use those hospitals, regardless of what's happened. For those hospitals where we didn't have a cap rate, that's where we speeded up payments. And we've accelerated them so that we pay electronic claims in 5 days and paper claims in 10. And to do that, we've suspended certain audits and things that you would normally do. And we do plan to begin to slowly bring those back in beginning at the end of this month. Now, if the pandemic goes on, and of course we're having a surge right now in Los Angeles, many of the ICUs are filling up. There's still capacity, but it's getting tight. So we'll have to review that as we go along. But I would say, by and large, the accelerated payments that we have made have been very helpful. And of course, having so much of our provider network under capitation has kept everything moving, and the wheels have been greased or oiled, or whatever the expression should be.
Well, and we've heard a lot, especially from the primary care community, that one of the things that we should take away from the pandemic is a more accelerated move towards capitation, which used to be a dirty word in the industry. Mm-hmm. Do you see that among your peers, that there is a broader conversation about the need to move more rapidly to a capitated model and away from fee-for-service entirely?
Well, a great number of the Medi-Cal plans here in California, there are 16 of us that are public entity plans. Many of them already use capitation and have for decades. So it's not so much of a brand new idea. And among the commercial insurers, I'm sure that they're looking at it because I think the providers would be demanding it. Now, we've had a lot more interest from hospitals that have not been under capitation to move to capitation agreements since the pandemic started. So we plan to move more of those that are willing, and we can come to terms with them, into capitation arrangements to avoid the kind of problems that those that depend solely on fee-for-service reimbursement are experiencing.
Great. And lastly, John, I want to come back a little bit to, I think this falls under the social determinant, the population you serve, but you're elevating the safety net program, which you, I think, just had a new grant go out earlier this month, early in July, I should say. Can you talk about that program and the importance of something like that in the context of what we're seeing now?
Well, Employing the Safety Net was a program we started in 2018 based on the idea that we needed to do something to make sure that we had an adequate safety net of providers, particularly physicians. There's a shortage of primary care physicians serving the underserved safety net population. And we thought, well, what are we doing about it besides complaining? So I asked our board of directors to set aside 5% of our unassigned reserves over 5 years, which has created a fund of $155 million. And we have basically 5 phases to the program. What you're talking about is the LA Care Scholars Program, where to build a pipeline for the future, we're supporting 8 full medical school scholarships a year, 4 at UCLA's Geffen School and 4 at the Charles R. Drew School of Medicine in South LA. And in that program, we provide the full 4-year tuition and expenses. And we said to the schools, you pick the students coming in the door that you think are most likely to return and work in the safety net here in Los Angeles, because you've been doing this for decades. And so that they've accepted that challenge. And I would say now this was our third class. So we funded 24 of these. 22 of the 24 people of color, over half are women. They're African American, Latino, Asian. And that's exactly what we're looking for, because that makes up the population of members we serve. And we all know that people respond better if their care provider is somebody who looks like them or sounds like them. So that's one element. Another element of the program was to help small practices and clinics recruit new primary care physicians, because they generally don't have the resources to compete with a Kaiser or some of the academic medical centers. So since then, we've provided 110 grants of $125,000 each to a clinic or a safety net practice that will bring a new primary care doctor into the safety net. They can't hire the guy across the street. They have to be new. And so far, 92 physicians have been hired, and about half of those have applied for another element of our program, which was to reduce their medical school debt. If they would agree to stay in the safety net for 3 years, we'd retire up to $180,000 of the debt. So that has brought 92 providers into the community, into the safety net, who weren't here before. We'd like to think that wouldn't have happened if we hadn't intervened. And the program is still cooking. We also support 14 residency slots, and I could go on. But I think this is very important, because access for the population that we serve has always been a problem. And if during the pandemic we see doctors dropping out because they are fee for service and they can't weather the change to telemedicine, which is the other big change, then we think that this program has been very helpful in making sure we have an adequate number of providers available.
Well, and certainly the pandemic and the public outcry over the death of George Floyd has elevated these conversations to more importance across the industry. So, John,
they have.
Listen, I appreciate all your time today. I know you're busy there in California and LA. Thanks for taking some time to explain your programs to us and share some of your insights of how COVID is impacting your marketplace.
Great. Well, it was my pleasure, and anytime, Matthew.
Thank you. And I'm Matthew Weinstock with Modern Healthcare. This has been The Checkup. Be sure to come back next Monday.